Thank you so much for that introduction. And it's truly not, I mean, this is something that um, I struggle with you guys as much as you guys struggle with your condition. And it's been 20 years and we're still trying to find answers. And fortunately, we're making some progress. We're trying to have a better understanding of these conditions. When I say conditions, I mean CRPS and all its associated conditions. When I started out 20 years ago, it used to be called RSD, and then um, other than doing a nerve block, there was no other option. It was nerve block and gabapentin, and that's it. But over the years, if you look through some of our past videos on RSDSA, you'll find a progression of how things have moved on. So with that, let me just start this presentation. I'm not going to talk a lot about CRPS, but I'm going to talk about some of the conditions that I have noticed that come along with CRPS. Some of them are caused by CRPS, and some of them are cause CRPS pain. The problem is that by definition, CRPS is pain that we don't know why you have it. And I think that part of the definition, that part of the criteria needs to be taken out, because we're now starting to understand that CRPS can be caused by other conditions. So with that, just wanted to start with a standard disclosure and disclaimer. I won't take up much time on that. So we know that there are two types of CRPS, CRPS1 and CRPS2. 99% of the patients that I see when they come to my office do not have a number next to the CRPS. And that is a problem, because the treatment even though their symptoms are exactly the same, the treatment is completely different. And that's where it differs a lot. So we talk about both, but I'm going to talk a little bit more about CRPS2. CRPS1 is, we don't know which nerve is exactly damaged. There's pain in my left arm, and I'm not sure which nerve it is, but something is burning in there. In CRPS type 2, I know the exact nerve. I know that the ulnar nerve is damaged or my radial nerve is damaged. And because I know what's broken, and that's how you treat pain, you need to find what's broken. Once we find what's broken, then that's when we move on to fixing it. So some of the treatments, so in CRPS type 2, the good news is that you know what's broken, you know which nerve is affected and how it's affected. And you'll see through this presentation when I talk about it, like, how do you figure that out? So obviously the symptoms are pretty much the same, but it's important to get into the history and find out how did it start, what happened, and that gives us a clue whether this is CRPS1 or CRPS2. Some of the treatments are the same in both, but there's one problem, is that in some patients, they can have both. So a patient, usually what happens is that will start out as CRPS type 2. They're not getting the right treatment. That condition gets neglected, ultimately winds up as being having CRPS1 at the same time. And this is because the treatment for CRPS, the person never got the treatment for CRPS type 2 in the first place. And now, because the specific nerve problem was not treated, they eventually go on to become presenting with CRPS type 1. So CRPS, it's strange that we call this 2 when this was the first CRPS that was discovered, even before CRPS 1. And you must have probably read in the history how during this, I believe, First World War, there were soldiers returning with brachial plexus bullet wounds. And Dr. Mitchell was one of the surgeons, and he noticed symptoms of CRPS. And what he did really notice was CRPS type 2, which he called at that time causalgia, and then it was eventually changed. So in CRPS2, most of the symptoms are similar to CRPS1, which is you have the color change, you have the temperature difference, you have the swelling, you have the sweating, all of those changes, you see them in 2 also. But in 2, there is a major nerve damage that can be identified, and that's really important. And that needs a careful examination to find out um, whether a nerve is affected, and if it is, then which nerve is affected. Some of the examples of CRPS type 2 I can give you here right now is in the arm, you can have CRPS type 2 from thoracic outlet syndrome. And this may sound something out of the blue, but thoracic outlet syndrome, CRPS, is extremely common. I've been surprised at how many cases I may have missed probably in my career. And also, now that I know this, I look for this and they get the right treatment and they improve significantly. The second is ulnar nerve entrapment. In the legs, it can be common peroneal neuralgia. We'll talk a little bit about Ehlers Danlos syndromes and how they can cause nerve damage. We'll talk about abdominal pain, that there are different types of abdominal pain, and one of them is called severe pain in your abdomen. That's called median arcuate ligament syndrome, also known as MELS. So let's talk about thoracic outlet syndrome as CRPS type 2. This often happens when somebody falls on an outstretched hand. So they're walking, they trip, they fall on their outstretched hand. You're on the road and you're trying to get onto the sidewalk and your foot gets caught on the edge of the sidewalk. You fall forward, you fall on an outstretched hand. You fall from a height, from a ladder or something, you land on your outstretched hand. The other reason it can happen is from a violent front-end motor vehicle accident. So you can see, they say drunk drivers, when they get in an accident, get away with nothing. This is the story. So when you see that you're getting into a car accident, let's say there's a car heading on the wrong way to you, or you're heading towards a tree, you brace yourself. When you brace yourself, you hold yourself against the steering wheel tight, and that eventually gets transmitted up into your shoulder, resulting in thoracic outlet syndrome. This is a pain pattern in thoracic outlet syndrome. Looks exactly like CRPS, looks exactly like someone's having pain from their neck, but this is completely different condition with a completely different treatment modality. So, one second. Did you do something to my mouse? Anyway, my mouse won't work. So this is a picture of a graphical picture of your chest wall. So this is the part it shows. You can see the collarbone up there, and you can see the first rib below that, and between the collarbone and the first rib, there's a gap. So just to show you, imagine this is my collarbone, and this is my first rib. The first rib is a flat bone, and between the two, there's a tiny gap. And in that gap, there are nerves and blood vessels that go down my arm. So they come out of my neck, they go over the first rib and down into my arm. When someone has an injury like I just described, they fall on an outstretched hand, what happens is the arm gets pushed backwards violently, and when it gets pushed violently backwards, then you see that muscle pec minor, that big red muscle, that goes into a spasm. When that goes into a spasm, it compresses that yellow nerve that you see as a neurovascular bundle, that gets compressed. It also can cause spasm of the scalenes muscle that you see on the top, and you can see the nerve is coming right through it. And so that muscle goes into a spasm and it squeezes the nerve going down your arm. So this is called thoracic outlet syndrome. And the treatment is very obvious, that you would want to release the spasm in these muscles, and that'll make a difference. So the treatment is in two types. One is to do Botox injection. So you can do they can do Botox injections into the pec minor muscle and into the scalene muscles. What Botox does is it relaxes the muscle or semi-paralyzes the muscle, and that opens up the space. So the nerve isn't getting squeezed too much. This is the pec minor muscle. And you can actually, if you feel on this area of the pec minor, and if you push on it, you'll feel the pain go down your arm. So they often do Botox, and about 70% of patients respond to the Botox injection. But there's about 30% that don't, and that's where you need surgery. And in that surgery, they'll usually go and remove the first rib, and that kind of opens up the space. And obviously, that's not the first choice. We don't like doing surgery in patients with CRPS. So that's a classical example of a CRPS type 2. Let's talk about a nice example of CRPS type 2 in the leg. Now, this can happen from overstretching of a nerve called the common peroneal nerve. The nerve lives just below and outside the knee joint. So this is the area of pain when that nerve is affected. Mostly the whole leg below the knee up to the foot is affected, but predominantly the pain is on the outside of the leg. It may be on the inside also, but it's mostly on the outside going into the top of the foot, which you can see as a purple area. And this is because the nerve, common peroneal nerve, is overstretched. Oftentimes, these patients develop foot drop also. So this is a schematic of where that nerve lives, and you can see over there. Let me see if I can move the mouse. Okay, so you can see a schematic over there where you have the lower two bones right outside the knee. So this is below the knee, and you're looking at the outside part of your knee. And the two bones meet up and form a joint called the proximal tibiofibular joint. And just outside that joint, you can see that yellow nerve, that's the common peroneal nerve, wind around the fibula. That thin bone is called fibula, and it winds around that. If for any reason that nerve is overstretched, then that nerve gets inflamed. And when that gets inflamed, you develop CRPS type 2. Now, what are the situations that can happen? One, it can happen in somebody who has a fracture of both bones. It has to be a fracture of both bones of the leg. It can happen in those cases. It can happen in somebody whose ankle gets inverted a lot. So you roll your ankle a lot. And that can happen. And that usually happens in patients with Ehlers Danlos syndromes. You'll see this, it's actually fairly common in these patients. They develop a transient foot drop. They develop pain down the side of their leg. And it's a simple exam. If someone were to press on that nerve, you can easily reproduce the pain going down the leg. And that's what it looks like. So the nerve gets inflamed, and in this case, it's an EDS case where you can see the bone has subluxed. It's moved away a little bit. But it doesn't have to be EDS. It can happen in somebody who's had fracture of their lower leg. So this is what I was just explaining to you, why people get CRPS of their leg from a peroneal nerve damage. So before I get into dysautonomia as a complication of CRPS, so I gave you two little examples of how it's really important to find whether it's a CRPS 1 or CRPS type 2. And it's, you can ask your doctor, like, do you think this could be CRPS type 2? And if he or she is not aware of that, you can also sort of look through the literature, look through some diagrams, and try to figure out, is it possible that you could have injured a nerve? Because if you look at this is a simple treatment. All you do is, actually, this is what the surgeons do. They go in there and they screw this little bone, the little bulb on top of that fibula, they screw it to the main big bone called the tibia. And that's all they have to do is fix it. So let's talk about dysautonomia as a complication of CRPS. Dysautonomia means dysfunction of the autonomic nervous system. So the autonomic nervous system, anybody who has CRPS knows what the autonomic nervous system is. That's the nervous system that controls all the automatic functions in our body, from focusing to blinking to breathing to sweating. Everything is controlled by the autonomic nervous system. It controls um, the blood flow to your limbs, and that's one of the reasons why CRPS was always thought to be that it was a dysfunction of the autonomic nervous system. But that theory has been proven again and again to be incorrect. Among the dysautonomy, there are many. Dysautonomy is an umbrella condition. There are many other types of conditions under this umbrella, and the most common one is called POTS, postural orthostatic tachycardia syndrome. In POTS, patients often present with dizziness, especially when they move from a lying down position to a standing position. They get a little lightheaded. They get palpitations. That means they can feel their heart racing. But more importantly, they have an immense amount of fatigue. So by definition, fatigue is tiredness that does not go away even after you have rested and slept. So you wake up tired, you go to sleep tired, you take a nap, and you wake up, you're still tired, and that's called fatigue. They do have headaches. The headaches get worse when they stand up. They have cold hands and feet, and they also have brain fog. They just can't remember things. They forget things. It's just a brain fog. Some days these symptoms are worse than other days. So how do you diagnose POTS? It's actually something that you can do at home. You lie down for 5 minutes, check your blood pressure and pulse rate, and then stand up for 30 seconds, and you check your blood pressure and pulse again for 30 seconds. Check your blood standing for 30 seconds, and then keep standing for 10 minutes, check your blood pressure and pulse rate. In POTS, the blood pressure does not change much. There's very little change in the blood pressure, but the heart rate goes up by 30 beats per minute in adults. It's 40 beats per minute in children, but in adults it's 30 beats per minute. So if your heart rate while you're lying down is, let's say, 60, and you stand up, it becomes 90 or 110, or if your pulse rate gets to 120, it's considered as POTS. Now, it's not precise. I mean, it's 30 beats, but what if it is 29 beats? I get this question a lot from doctors. Well, the change was only 29 beats. I mean, give me a break. There's not much difference between 29 beats and 30 beats. But basically, if you have these symptoms, start suspecting POTS. You're getting lightheaded when you stand, you get heart racing or palpitations, you get this unexplained fatigue, headaches that get worse when you stand, and brain fog. These are some of the more important symptoms. I can't go into the treatment of POTS entirely over here, but the treatment is usually increase your oral salts. Of course, if your blood pressure, remember in POTS, the blood pressure doesn't change much. And most often patients with POTS have a very low blood pressure. So we recommend taking oral salts. You can take salty foods, you can add extra salt, you can even take salt pills. You increase your electrolyte fluids. So 16 ounces of electrolyte fluids a day. There are many types available in the market. There's Gatorade, there's liquid IV, known, all sorts, drip drop, all sorts of electrolyte fluids. These are sports drinks. And 16 ounces per day will make a big difference. This is often treated by cardiologists and neurologists, and either one of them are good enough to see and confirm or not confirm. What I didn't tell you was, when they officially diagnose somebody, instead of doing this test, they do what's called a tilt table test. Essentially, they strap you to a table and then they do the same thing. They tilt the table. And if you have POTS, it's brutal. Other drugs that can be used is Mastinon, Corlanor, and compression to the legs. But I would recommend looking at this website called Dysautonomia National. They have a lot of information on POTS and other types of dysautonomias. So you could have, say, hyperadrenergic POTS. You could have POTS. There are different types, and see if you fall into that category. It's really important to do that because most physicians do not think of POTS when they see someone who's lightheaded and dizzy. They attribute that to anxiety and write you off on that. So the thing is that this is a treatable condition. You can treat it. You can do all these simple treatments like taking salt and increasing your fluids and all that. So it's treatable and it can be fixed. Your fatigue can be fixed. Your brain fog can be fixed. And that's what makes it so important to understand. Now, just so you know, POTS does not cause CRPS, but it can be a complication of CRPS. So somebody with CRPS can have a complication with POTS, but POTS itself is not painful. Mast cell activation syndrome, or also known as MCAS. By the way, you're now going to, the good news, well, sort of good news about POTS and mast cell is that you're going to read a lot about this. Doctors are going to know a lot about this because these are the two complications of COVID-19. So about 46%, between 36 to 46% of patients who get COVID and survive it, they develop what is called long COVID. And it is nothing but POTS or dysautonomia and mast cell activation syndrome. So some good, I hate to say that, but some good has come out of this COVID pandemic. So anyway, what are the symptoms of mast cell activation syndrome? These are unexplained rashes or hives. You have unexplained itchiness, fatigue, tiredness, muscle pain. It's a very painful condition. It's like your entire body hurts. It feels like bone and joint pain. It can cause belly pain. It causes cramping, urgency, diarrhea. It can cause bloating. They often get flushing after a temperature change. So if you come out of a hot shower, you get in a cold bathroom, you'll see flushing over your skin and chest wall. It can cause bladder pain. Not in all, but a lot of these cases we see that. The easiest way to explain mast cell activation syndrome to someone is it feels like you have flu. You have flu-like symptoms. It feels exactly like that. You're tired, everything hurts. You want to stay curled up in bed. You're hot, you're cold. That's exactly what is mast cell activation syndrome. And this can cause CRPS. And this can also be a complication of CRPS. So what is mast cell activation syndrome? These are mast cells that are normally found in the body. Everybody has them. They're part of the immune mechanism in our body. So when the immune system detects some sort of a danger, it tells these mast cells, it activates these mast cells to do their job, which is to release chemicals like histamine, cytokines, tryptase. Histamine is, how do I explain? If you have ever had hot chili pepper or even black pepper, just plain black pepper, the burning sensation from that is histamine release. Cytokines are like little text messages that tell your cells that, hey, pain, pain, pain. They send little text messages. Tryptase is a chemical that's produced by these mast cells. Tryptase, that the best way I can explain it is that it is a chemical that they often use in the meat industry to tenderize meat. So it really, if having a meat tenderizer run through your body, that's the level of pain these patients can have. Histamine and tryptase lead to release of something called calcitonin-related gene peptide, CGRP. This is something that I'm really very excited about because we now have drugs that act against CGRP. We now have a lot of drugs, not just a few. We have a lot of drugs, both as injections and as tablets, which act against calcitonin-related gene peptide. They have only been approved for the treatment of migraine. Excuse me. But that's a whole different reason why they did it for migraine only. But eventually, it has been very successful in the treatment of migraine. And eventually, I think this may in the future be the treatment of nerve pain or neuropathic pain. So really excited about that. And then you also have substance P. Substance P just became very famous. One of the scientists who got the Nobel Prize this year was the person who worked on substance P. So substance P, CGRP, these all, so these histamine and tryptase release CGRP and substance P, which then causes the nerves to get inflamed. So there are all these people acting against your nerves. You have histamine, cytokines, tryptase, CGRP, substance P. They're all working. Actually, I haven't even listed all of them. If you want the list, here's the list of all the chemicals that the mast cells release. There are lipid mediators, cytokines, and all sorts of names. But what I'm trying to say is that why would somebody have mast cell activation syndrome? Like, if I have I have patients in my office, they don't have an injury, they don't have an infection. So how come they have mast cell activation syndrome? The reason they have it is because the mast cells in these cases are misbehaving. And that is what we don't know why. Why do patients with those who are recovering from COVID have this feeling, especially the ones that have long COVID? Why do they feel so tired and so fatigued and so achy and painful? Their mast cells are going crazy, and we don't know why. And so that's one of the things that's still up in the air. But anyway, I wanted to show you in this. The purpose of this slide is to tell you exactly which organs in your body they can affect. But essentially, they can affect every single part of your body. So they can cause problems in the brain, like brain fog, headaches, dizziness, confusion. They cause a lot of neurocognitive effects. They increase your heart rate. They cause dizziness, fainting, something similar to POTS. Actually, what happens is mast cell activation syndrome, or MCAS, also triggers POTS. It does cause a lot of GI effects. It causes bloating. It causes nausea, vomiting, and abdominal pain. It's a diffuse belly pain. It can cause burning in the urine. It can cause asthma-like symptoms, joint and muscle pain, and then hives and itching. So mast cell activation syndrome is like having flu. You're tired, you're cold, you're sick, you have no appetite. It adds to the fatigue. It causes loss of appetite, diffuse pain, and it worsens POTS. How do you treat it? So this is the very basic treatment for mast cell. There are more advanced treatments on this, but usually when I treat my patients with mast cell, I start with this, and then if they're not getting any benefit from this, then we move to the more advanced part, which then they have to see a immunologist. So the first part is to take drugs that work against histamine. So antihistamines like famotidine, which is Zyrtec. Pepcid, Benadryl or Zyrtec. Any cold medicine is an antihistamine. Then you take mast cell stabilizers, and there are 3 of them: cromolyn, ketotifen, and quercetin. Quercetin is over the counter. The third part is to look for the triggers, and it could be something that you're eating, or it's something that you're breathing. Food. There's so much. I'm just going to hold off on my French, but there's so much junk in the food. There's gluten in the food. There's sugar in the food. There's who knows what they're feeding cows and that ones that we're eating. So there's a lot of this stuff is we're eating them. Our bodies are not designed for that. The grains that my grandmother took is not the same grain that I'm taking. It's a different bread. Look for something in your house. Is there mold in the house? Is there something in the house that could be triggering it? Color dyes. People don't know this much, but color dyes, especially red and blue dye, are notorious for triggering pain. I personally know that these 2 dyes trigger my migraines, but they are notorious for it. So try to take drugs. You don't have a choice when you get a pill at the pharmacy, but try to not drink fluids that have dye in them. CRPS, pain in the abdomen. So we talked about one of them, that is mast cell activation syndrome. So in mast cell activation syndrome, what happens is these mast cells, they accumulate, they line the lining of the intestine. So they cause inflammation of the intestine. Now, the intestine is a very picky organ. The minute it sees something's wrong with it, it stops functioning. So you start getting bloated, you start getting nauseous, and that's where these people have diffuse. It's not severe pain, but it's a diffuse belly pain. But the really severe pain is called median arcuate ligament syndrome, or also known as MALS. I should have put a picture. This pain is, I don't know if you can see me, but this pain is in the upper belly, right where my hand is. It's in the upper belly. Usually, it comes on immediately after you eat food. As soon as you eat food, you get the severe pain in your belly. It's like a sharp shooting pain. It's like a CRPS pain. You get really tired and lethargic after eating a meal. Any activity or exercise can make this pain worse. It gets worse with standing, but it gets better with lying on your left side or your right side. It gets much better. This is a picture. Basically, what happens is that you can see that there's an artery that sort of peaks below a ligament called the median arcuate ligament, and this artery comes out, and that's the pink color, this pink snake-like looking structure. That's the artery. This then feeds blood to the intestines, and in MALS, what happens is, that's the picture on the right side. In MALS, the ligament tightens down. For whatever reason, it tightens down. When it tightens down, it squeezes that blood vessel, which means part of your intestine is not getting blood supply. That's not just that's the one problem. The second problem is, you see that little blue line that's snaking over the artery? That's the nerve. It's the celiac plexus. And these nerves go to the intestines also. And when this ligament presses down and squeezes the artery, it also squeezes the nerve. And so these patients present with both nerve pain and vascular pain. It's a severe, excruciating pain in the abdomen. That's the bad news. The good news is that surgical decompression makes a big difference. Patients pretty much get almost, I would say, 90% response from it. They do much better. The trick here is that you have to see an experienced surgeon, somebody who is very familiar with diagnosing MALS and treating it. There are two types of surgeons over here. There's the one type of surgeon who what they do is they simply go and release the ligament, and they leave alone the nerve. The other school of surgeons, what they do is they not only release the ligament, but they also remove that nerve. And from what I've seen in my patients, I send them to a surgeon who actually who also removes the nerve and also releases the ligament. The results are much, much better, because that nerve is now a CRPS nerve. That nerve is painful. And so opening up the ligament is not enough. Removing the nerve at the same time does make a big difference in these patients. I've seen patients from both sides, and I can see the difference. So finding an experienced surgeon is the hard part. Wanted to talk to you about Ehlers Danlos syndromes. This is not a condition that happens only in kids. It happens in adults also. It's just not caught in time. So I get to see a lot of them, both kids and adults. It's also known as EDS, and briefly, but what this means is that the human body is made up of tissues, and tissue connects everything. So you have a skeleton, and plastered on that is all this tissue, muscles, ligaments. They're all plastered onto the skeleton, and they connect everything together. And so hence they're called connective tissue. The difference between a person with EDS and without EDS is that in a person with EDS, the connective tissue is very soft and stretchy. It breaks easily, and when it breaks easily, it's very difficult takes much longer to heal. Their ligaments are very elastic and stretchy. In a person without EDS, the connective tissue is pretty stiff, so it doesn't break easily. And when it does break, it heals up very quickly. So the diagnosis of EDS is clinical, and that is one of the problems your patients are going to face is, oh, you need to see a geneticist. There has to be a genetic test and genetic study and all that stuff. There are 13 different subtypes of EDS, and of the 13 types, the most common one is called the hypermobile type, and the other 12 have a genetic test. But the hypermobile type, which is 98% of these patients with EDS, there is no genetic test. So the diagnosis of EDS does not depend on a genetic test in hypermobile type. It is it's a pure clinical exam. So the question is, how is EDS related to CRPS? And that actually is a small story I wanted to tell you, was because my focus used to be on CRPS. And for the longest time, I was treating CRPS. Then I got the local pediatricians asking me, hey, can you treat our CRPS patients, the kids with CRPS? And I said, sure. And that's when I noticed that they all had this one common thing, that they all had loose joints. They were all dislocating their joints, and they all had EDS. So EDS is very closely related to CRPS. Because the joints dislocate, the nerve that travels over the joint becomes overstretched. And I'll give you an example. Remember, we talked about this nerve that's near the knee joint. And so when the two bones separate, that nerve gets overstretched. The peroneal nerve gets overstretched, and they develop symptoms of CRPS down their leg. So if they don't get stretched, they can get pinched between a bone or a muscle, or a bone and bone. They can get pinched there. Give you an example: thoracic outlet syndrome. So over here you can see the nerve getting pinched between the muscle and bone. On the scalenes, it's being pinched between muscles, and on the pec minor, it is pinched between the muscle and the rib cage. So over here they're getting pinched in thoracic outlet syndrome, in foot drop or common peroneal neuralgia. The nerve gets overstretched. And nerves don't like getting overstretched or pinched. And that's the same story with the spine. The spine becomes unstable, especially the neck. When it becomes unstable, it compresses the nerves, and that can lead to symptoms of CRPS. Tethered cord syndrome, which is more common in patients with EDS. We see that a lot. In this case, the spinal cord is under tension. Normally, the spinal cord is supposed to be hanging loosely in your spine, but in these people, they're born with tethered cord. The spinal cord is under, and when it's pulling on your spinal cord, think about what it's doing is it's pulling your spinal cord, it's pulling on the nerves, and so these patients present with mostly pain to their legs. They have this CRPS-like neuropathic pain to their legs, and this is a picture. On the left is a normal spine, and you can see the spinal cord ends at L1. On the right, you can see a tethered. You can see the spinal cord ending at L3 because it's being pulled down. The treatment for this is a very simple surgery, and so they go in there and they surgically release that thread that's holding it. Now, this is the elbow. And behind this elbow is the nerve called the ulnar nerve, which is what we call as a funny bone. And if you tap on it, you get the zing down your arm. And that sometimes what happens is that when the elbow joint goes out of space, out of its place, it can cause the ulnar nerve to be overstretched, and that can cause pain or CRPS-like symptoms on your arm. Or it can also happen when there's a ligament. So on the left is a normal one, and this is like taking a knife through somebody's elbow. You can see, just look at the ulnar nerve going through the middle of the ligament called Osborne's ligament. And then you see on the right, when this gets dislocated, when the olecranon or the two bones get separated, then the ligament gets tightened. And when it becomes tight, it compresses the ulnar nerve, which then causes symptoms of CRPS down your arm. Small fiber neuropathy is strictly not CRPS, but it can mimic CRPS. So this is imagine your spine, the nerves in your body are like the roots of a tree. They're the thickest in the middle, and then as they spread out, they become thinner and thinner and thinner. By the time they reach your fingertips or your toe tips, they've become really thin and fine. And so if anything was going to affect you through your body, let's say mast cell activation syndrome or an autoimmune discondition, then these thin nerve fibers would be the first ones to be affected. So they often present with what we call as glove and stocking distribution. So you can see it starts in the feet first, because that's the furthest away from the spine. And they start to develop this pain, which mimics CRPS quite a bit. The big difference is that it often happens in both feet at the same time. CRPS usually starts in one of them, but in this case, it starts in both. They have difficulty with temperature perception. They have touch sensation is gone. It almost feels like CRPS. This usually will happen in patients with more systemic conditions like autoimmune dysfunction, or in patients with, well, we'll get into that later on. But remember the autonomic nervous system? We talked about the nervous system that controls automatic functions. Those are also small nerves. So they get damaged too, and that's the cause of dysautonomia in this case. So they have decreased thermal sensation. They can't feel heat. They have decreased pinprick sensation. They have numbness. They have pain. This is a pretty horrible pain. They have this creepy crawly sensation, or they can have a combination of any of these. So they often complain of burning in their feet. It usually happens at night. They have pain to touch, so they always like to keep their bed sheets off their feet. They have numbness to the toes. They feel like wood. That's the exact word they tell you. It feels like wood. And it also feels like they're walking on pebbles. Now, we don't exactly know why small fiber neuropathy happens. But one of the things that we've come to know is that there's a glucose dysmetabolism. That means your blood glucose levels are not perfect. So even the slightest glucose range changes, these patients can develop small fiber neuropathy. So the most common cause of small fiber neuropathy is unknown. And that's the problem. In fact, most cases, we don't know why they get small fiber neuropathy. It could be age related. It could be anything. It could be exposure to some toxins. It could be exposure to some mold. Any of those can do it. The testing is usually normal because the cause. It could be immune mediated after an exposure to a viral infection. You have a cold or some sort of infectious mononucleosis, and all of a sudden you have this symptoms of small fiber neuropathy. Other things that CRPS is associated with is migraines. People with migraines are prone to having CRPS. People who are on ACE inhibitor drugs, like lisinopril and all those kind of group of drugs used for treatment of high blood pressure, are prone to getting CRPS. I just put in there because I didn't know what am I going to do with it, but just so you're aware of that. So what are the reasons for pain in EDS? One is POTS, dysautonomia. That is common in EDS. Mast cell is common in EDS also. And small fiber neuropathy is also common in EDS. So people with Ehlers Danlos syndromes have enough reasons to have pain. We're not even talking about the joints over here now, but these are just some of the reasons why they have pain. So in summary, there are two types of CRPS, CRPS 1 and 2. Really important to know which one you have because it changes your treatment and outcomes completely. CRPS may be associated with POTS. Whether it's 2 or 1, it can be associated with POTS, lightheaded, heart racing, brain fog, severe fatigue. It can be associated with mast cell activation syndrome, which is diffuse body-wide pain. It just feels like you have flu. Abdominal pain in CRPS can happen from mast cell, and it can happen from median arcuate ligament syndrome, where I told you about the nerve and artery being pinched. It can happen from overstretching or pinching of nerves in patients with ADS, or it can happen in non-ADS patients after a fracture or some sort of a major trauma. And then you have small fiber neuropathy, which kind of mimics CRPS, but is not the reason for CRPS. And so with that, I'd like to thank RSDSA. I'd like to thank everybody who has helped. And I'd like to put in a word for the auction. It does help. I've been with the RSDSA for a long, long time. And the work they do is just amazing. So over to you, Alexis.
Awesome. Well, I see Jim has already turned his mic on, so I think Jim may have a question to kick us off.
I was wondering, Dr. Chopra, we had some questions about stem cell therapy, mostly for CRPS. Do you have any experience with that?
So there are two kinds of stem cell therapies. One is which you can find pretty much in every street corner now in the United States, where they draw some blood, they spin it, they get some they get some platelets out of that, and then they inject the platelets, and those platelets will then cause tissue repair and regenerate. So it's also called regenerative medicine. That usually I think is more limited to specific joints pain. So supposing you have arthritis of the knee joint, it'll help there, but you can't. It won't help diffuse CRPS pain. At least CRPS 1 it won't, and CRPS 2, of course, you have to treat the reason for the pain. However, for CRPS 1, there is one treatment that is being looked at is where they draw fat cells. So fat cells, there are cells called mesenchymal cells, or MSCs. These fat cells or mesenchymal cells, they basically do a mini liposuction, stick a big old needle into the belly or in the butt, and they suck out a little bit of fat, and then they process it in a lab, and they grow these MSCs. They grow these stem cells till they get to a few million, and then these are then infused back to the patient, and they go to wherever there's a damage in the body. They make a beeline for that. So let me just clarify that again. There are two types of stem cell therapies that I know of. One is where they take a blood sample, they spin it, they get some platelets out of that or stem cells, and they inject it locally. So that would go for a particular joint or something. That cannot be given to the entire body. You only get a few thousand stem cells from that. The other technique is to draw fat cells from your body, and they then grow them till they get a few million. Once they get a few million, then they put that back into your body through an IV, and that can then those stem cells. So you ever think of stem cells as clay? They have no shape, they have no purpose. But once you inject them, they find a purpose. They find where the damage is, and they make a beeline for that and start the repair process there. That's the advantage. So yes, the first one may or may not be as helpful, but the second one can definitely be very helpful.
Thank you.
We did have a few questions that came in through the chat as well as our Q&A portion. So I'm going to, of course, ask a few questions that are not directly specific to the warriors that have asked them, with as much time as we do have. So we do have a pretty general question that is asking about CRPS and spreading. How do you know if your CRPS has spread or if it's just something else? How many tests do you have to do, or how long do you wait?
Okay. There's no testing. It's very simple. So let's say somebody has CRPS of their left leg, and now they're starting to develop pain on their right leg. There can be two reasons. One is the CRPS is spreading, or it can be because they're overusing their right leg. And you can make out the difference, because if the right leg looks and starts to behave the same way as the left leg, like pain to touch, and then there's temperature difference, there's it's cold, it's color, you may even see a color difference. It pretty much mimics the one on the left side, but at a lower degree. That's CRPS spreading. And that's from a phenomenon called central sensitization. And you'll find that there's lots of information online. There's lots of information on the RSDSA website on central sensitization. I've talked about it a lot. But the other pain that is because of compensation is not the same severe pain. It's more localized. It's more localized to the joints. CRPS pain never goes down. It's always there. It's a constant pain. I mean, you're lucky if it goes on from 10 to 9. But if you have it because you're compensating, then that pain on the right side will go down, say, with rest or something. That's how you differentiate it.
Question. Now, we have had a lot of
What about
warriors.
the answer?
Oh, yeah, great and
Great
answer.
answer.
Excuse me.
Yeah.
Great question and great answer. Excuse me.
Get that right.
We did have, well, I guess I'll say over the last year or so, we've had a lot of warriors who have asked about, getting the vaccine. And we definitely have a lot of answers about that on our Facebook page. I can link you all to that if you are watching. However, we have had some warriors who have had breakthrough cases and their symptoms have flared and have not gone back to where they were before they had COVID. Have you heard about this happening to any other CRPS warriors? And do you have any ideas of how they can be helped?
So this is a very challenging question to answer. So the way I look at it is that, okay, if I had CRPS, I already have CRPS. Do I want COVID also at the same time? That's the risk. And so that's one question that you should be able to answer. Like, if you already have CRPS, and what if you get COVID? Things are going to become a lot worse. What if you get COVID and you recover from it and you wind up with long COVID? That's even worse. The problem with the vaccine is, well, there's no problem with the vaccine. The thing is, yes, you can get a reaction if you have an autoimmune condition. Your autoimmune system is going to go, a vaccine is basically, sorry, the COVID vaccine is basically, what it does is it tells your immune system, look, if you ever see this RNA again, this particular sequence of RNA ever again, fight it. It's a bad guy. That's how it works. Now, in the vaccine, they do have to put other things, other chemicals in it to preserve it, and so that it can be transported across borders and all that stuff. And those might cause a little bit of a reaction. I haven't come across anyone that has had a severe reaction, but I've heard about that. But those are far and few. In general, people have some sort of a reaction. They're pretty ill for, maybe a few days to a week or two. Nothing that Benadryl and Tylenol will not take care of. But it's at least you're protected. And there are only two things that will protect you from COVID, and that's the mask and the vaccine. And the risk of COVID is extremely high because there are a lot of people who are not vaccinated, and they can pass it on. You can get COVID after a vaccine also, but the symptoms are very, very, very mild after that. It's more like a cold.
Okay, great answer as well. Jen, did you have another question?
You're a good learner.
Dr. Chopra, some people talk about mold as a mitigating factor with CRPS and EDS and whatever. And do you generally test for that?
I don't test for mold because there's only so much my one brain cell can hold. So there are smart people out there who like are masters in treatment, in detecting mold and treating mold. So the question is, I'm pretty sure my house has mold somewhere. We live in a very cold country. Our houses are sealed. It may get damp, and then something will start growing somewhere. And how come I don't get the mast cell reaction as my neighbor? And the reason is it's all based on their immune system. And my neighbor's immune system might be not as good as mine, and so he responds to he gets sicker with exposure to mold. So the way I tell my patients that if you think that you may have mold in your house and if that's bothering you, you'll know once you go into that room, you'll get that feeling of sickness and you don't feel well when you're in that particular room. If you can't find the reason and you think there's something in the room, then just get a HEPA air room filter, and they're not that expensive, and let it run 24 hours. Let it just clean out the air. But mold has become a really big issue in patients, and a lot of it that has to do with a lot of our immune system, and our immune system is going through some major changes. That's my feeling personally.
Thank you.
So it is almost November, which is really crazy to think. And a lot of people are getting ready to hopefully travel and see family if they are able. So do you have any suggestions for CRPS patients who are able to fly and how they can avoid flares with elevation and cabin pressure? Anything along those lines?
Well, during flying, besides getting bumped by people in the line or being bumped by, all of that, avoiding that, the other part is when you get on the plane and they pressurize the plane before it takes off. So if you're sitting in the plane, you'll hear this big whooshing sound, and that's when they're pressurizing it. And the pressure, they continue to pressurize it as it attains its height. Once it reaches that height, it stops pressurizing it. And then when it's time to land, it starts to depressurize. Those are the two times, pressurizing and depressurizing, that's when it hurts the most. Unfortunately, there's no great solution to that. If you have a medicine that works for you, I would not only take it ahead of time, I would take it on the flight, especially as the plane takes off. And again, when you know that the plane is going to land, so about half an hour before that, take it again. Because pressure changes, even the barometric pressure changes that you get with the weather changes, even that affects pain a lot. And there's really no good answer to that other than preemptively working on it.
Alexa can't hear you. Alexa.
I was still on mute. So I know we are a couple minutes over time, but I did have a few other questions that I wanted to try to get in. I know Jim's device is now speaking to him. He said my name. But many of the CRPS conditions you mentioned are also associated with EDS. Does the same apply for HSD? So can hypermobility spectrum disorders cause CRPS? Hopefully I did not miss that part.
No, it's fine. So what happened was in 2017, we sort of sat down. There was a big meeting, and they wanted to firm up the diagnosis of EDS because there was a lot of confusion. Is it joint hypermobility and all sorts of confusion? So they had this. What they did was patients who presented with very specific symptoms, they said, this is EDS, okay, hypermobile EDS. But then there was this group of patients that have a couple of joints that are loose, not really meet the criteria for EDS, but have some of the symptoms. So it's like a little brother to EDS. And that they put that down as hypermobility spectrum disorder. So you're on a spectrum, but you really haven't attained that level of being a full EDS. So all of the stuff that I talked about applies to HSD also. There's no difference between the two.
Dr. Chopra, can POTS come and go?
You mean like forever?
I mean, no, could it be episodic here, then it goes away, comes back?
Oh yeah, it's very episodic. There are what we call as a potsy days. So there are some days you just wake up and you're so potsy, you're just brain fogged and lightheaded and just awful fatigue. Those are called potsy days. And potsy days, what I found is the best solution is chug a tablespoon of salt and wash it down with some electrolyte fluids, and that'll get you through the day.
Thank you.